Welcome, everyone, to another episode of the Two Sleuth Podcast. On today's episode, I'm super excited to welcome my friend, Lynn Pencek. So, my friend Lynn, she brings a unique balance of industry knowledge and clinical experience to all of her presentations. As a member of the Nobel Biocare team, she helped offices bring in new technology and develop efficient workflows for dental implant treatment. Lynn has experience with surgical assisting, clinical workflows, digital case planning for guided surgery, account and inventory management, marketing, and patient education for case acceptance. Being a dental hygienist, Lynn wanted to learn more about the care and maintenance of dental implants than what was already provided. Having a passion to unravel the questions and common misunderstandings dental hygienists have about dental implant maintenance, Lynn has founded her own company called Practice at Your Best. Welcome to the show, Lynn. Thanks so much for being here.
Greg, thank you so much for having me. What an
I'm
exciting
so
time.
excited to have you on today. Yeah, I mean, you and I met. When we first met, what I really love is that for me, in Full Arch, I start with the patient experience from holding the marketing companies accountable, to make sure the phones ring. And then from initial inquiry all the way through creating a raving referral for a patient, right? So every step of that patient journey from the time they come in, lead call, time they come in, dental assistants, treatment coordinator, treatment presentation, doctor-led consult, if that's the way it goes, all the way through surgery, post-ops, and then final delivery of that brand new smile. But then that's really where things stop, but it's not, because that's where you pick up, and it's that cleaning, hygiene, maintenance of this huge investment, $20, $30, $50,000 of that patient. So tell me a little bit about how you got interested in that, or where you saw a gap to be able to create your own business called Practice at Your Best.
Greg, when you talk to dental hygienists, the amount of training they have about dental implants is 2 classes in the periodontal semester, the advanced periodontal techniques semester. There's really not a lot taught about implants in dental hygiene school. And hygienists will defer to the plastic instrument, and they'll talk about scaling and root planing an implant. And you think about this, the implant's made of titanium, so you're really not root planing. You can't remove root surface. So there's a lot of misunderstandings, and implants are not like teeth, so we really can't treat them the same. So, it starts with the dental hygiene education. I find dental hygiene practice is kind of like being in a fishbowl. You're either in a practice who sees a lot of implants, or you're in a practice that doesn't. And if you change fishbowls, I mean, one of the things I love about clinical hygiene is you can temp and you can see what other offices are doing. This way, if what you're doing in your office is acceptable. If somebody's doing something better, you can learn. So it's fun to play in other people's fishbowls when you're doing temporary type work. I started working for a periodontist who was one of my accounts when I worked for Nobel Biocare, and he was a great mentor. And he brought me into surgery as a fantastic educator. And when I stopped working as a sales rep, I had some family business to take care of, and I was trying to reinvent myself. And he called and he's like, I need a hygienist. I'm like, I have some free time. I have a Jersey license. I can come help you out. So I've been helping out Dr. Childers, and every day is a learning experience. And you realize what you think you know. There's so much to learn about it. And there's not a lot of information about this topic readily available. You've got to really look for it and then look at the date and see up to date the information is.
Well, and I love that I love that you bring that up, because so many of us that have come from the manufacturing side, especially if we come from the implant manufacturing side, there's not a whole lot that we're taught or a focus and attention on anything after the sale and placement of the implant, right? Does it integrate? Awesome. Lab relationships, great, because you have to have the right prosthesis and the right implant abutment connection. Awesome. Maybe a little bit on the tooth itself, maybe, right? Is it screw retained or cement retained? That's really about it. But as far as maintenance, not so much. And when you think about it, it's, is there bone recession? Well, that can have a lot to do with the maintenance, right? That can have a lot to do with the hygiene. But, for someone like myself, 17 years in the industry and dealing with dental implants, I can tell you there's just not a lot out there. So, and you mentioned this, so where does somebody go if they aren't getting it from, even if they're not an implant manufacturer, but just in general on what does it look like for good implant hygiene maintenance, just at a surface level, and then we can drill down into some more of what you do and how you provide that education. But where's a good resource to start? Square one.
I I went to the Susan Wingrove textbook for peri-implant maintenance for the dental hygienist. It's a fantastic textbook. I also bought the Mish textbook. The Mish textbook is 14,000 pages, 40 are on maintenance, and it could use some updating. The Wingrove textbook is fantastic, detailed at every level, and just a great resource to have. So I honestly think any hygienist working in an implant practice, it would be a smart investment to have for those questions. What you're using isn't safe, this is not safe. You think about this with maintenance visits, we have three components: assessment, home care, and then the actual treatment. And you really can't just go right in and treat all implants the same, because you need to assess, where is the attachment? Is the tissue healthy? Is it a mucositis and reversible? Do we have that mucogingival attachment above the microgap? What is a microgap? These are things that hygienists are not taught about. And then if there's bone loss, and if there's bone loss, was the bone loss because of peri-implantitis, or was the bone loss because of insufficient buccal bone or insufficient soft tissue? And so there should be a communication between the surgeon who places the implants and the restoring office if it's a collaborative type case. So you'll find these full arch cases, they're either all in-house or it's a surgery practice with a referral base of general dentists or prosthodontists. And so how do you communicate between the hygiene team and the surgeon to assess, is the assessment, do we think that this is just mucositis, it'll resolve with better home care and more frequent maintenance, or is this a case where you need to go back in, graft, rebuild attachment around the implant? So that's a conversation hygienists don't have. And that was, me as an implant rep, I was just blown out of the water by all this and embarrassed for what I didn't know. And then you realize, okay, a lot of people don't know this, it's just not taught. So I felt better. I felt like therapy putting together the class.
Well, and you bring up some good points, because, Travis Rogers was on the show fairly recently, a couple months ago, and he talks about that referral network and the communication apparatus, and whatever it is and whatever platform you're using for communication, especially if it's not all done under one house, or even if it is, like, that communication apparatus is critically important between placing of the implant, restoring of the implant, and then maintenance of the implant. So there is a very good, accurate, up-to-date communication on every step of, to be able to follow through. I mean, we do it with natural teeth, but with implants, it seems like there's a falling off, and I appreciate you bringing that forward. Well, let's go back a little bit in time, because I want to pick that conversation up, but let's go back in time a little bit. I'm always curious about people's journey of how they got into dental and into dental implants, because most of my listeners know I kind of fell into it. I was in rental car back in the mid 2000s, and that was a cluster. And I was looking in medical device and happened upon an opportunity in dental, and I was up against 7 others for this position that I was foray into dental, and happened to get it because I'm kind of bold and I am who I am. And I've never left. I just think it's an industry that's so fantastic, that's collaborative, that's, it's a great niche, and I don't know that I'll ever leave. I never say never. Well, I guess I just did. But so I'm curious about your story of, how did you end up in dental? Like, what's your founding story in dental that now leads you where you are today? But I want to know the beginning.
Fun.
Yeah.
I was 6 when I wanted to be a dental hygienist.
Oh boy.
So okay, no, there's real science behind this decision. Think about this here. I was born in Watertown, Utica, New York, which is one of the towns where the water fluoridation studies were in the 60s. So my family moved from a fluoridated area to a non-fluoridated area. And here I'm this unusual child at the dentist not getting cavities, where my siblings did, because there wasn't water fluoridation when we moved to Binghamton. So I would go into the dentist and they would look and they would be so impressed, and they'd bring other people to come in. And so I was getting all this positive reinforcement for not getting cavities. And I thrive on positive reinforcement. I'm a puppy. Scratch me behind the head, behind the ear. I'll work harder. So I'm like, this is it. I want to do this when I grow up. Through high school, there was no looking at any other option. I was in dental hygiene school right after graduating high school. So I fell into it. So I practiced for 10 years. As a hygienist, I was faculty at Thomas Jefferson University here at Philly when they had their program. And I was, they encouraged us Pick a topic, write about it, research it, see where it goes. And I took the topic of ergonomics. And when Jefferson's program was closing, I took a position with orthoscopic research and got to do a lot of information about ergonomics. This does fall into the implant section. Check this out. The Danaher company purchased Nobel Biocare and orthoscopic, and I would be invited to a bunch of implant classes as the loop rep. And so you're watching, you're sitting through these classes, you know what you know, and the opportunity to become an implant rep happened. And I was at a point where I couldn't travel like I did with the loops. So I took up on the opportunity to take the South Jersey territory, which was just crossing a bridge as opposed to driving 3 states. And I thought I was making a quality of life and an easier choice than what I was doing. And I had no idea the implant industry was
To become an implant rep. Little did you know.
Oh my God, I'm 2 days in training. I'm like, holy cow, what did I? Because they're just throwing so much at you. And I mean, you want to, when I was with the loops, I knew I was a high functioning rep, and I expected myself to be at that same type of level with implants. And that doesn't happen in 2, 3 years. That takes 15 years to be at the level of the senior rep. It takes a lot of time to understand and be comfortable with it. So blown out of the water and really struggled as an implant rep. Some people can hide what they don't know or be comfortable not knowing what they don't know. I'm not one of those people. So I mean, like I'm getting up at 5 a.m. and I'm studying and I'm trying to like figure out where I'm missing the information and doing these, the webinars in the evening and trying to just bring in as much information as I can. And it was overwhelming. So I was, at 3 years, I was pretty functional. And when they decided to eliminate my territory, which worked for my advantage, I had to start taking care of some family members. I was like, this gives me the opportunity to really focus on one topic. And one of our colleges asked me to speak at their alumni day about implants. They asked for 2 hours, and I realized to explain it to the level that I was comfortable takes about 3 hours. For basics, for hygienists to understand basics so that they can apply their decisions to maintenance. So I mean, it was this accidental journey to get into where I am. But I realized when it was time to start looking at other options, it's like I put way too much into learning about this to walk away from it. So we really should take this information, apply it. I reached out to Susan Wingrove. I reached out to the author of the Wingrove textbook, and I said, I want to do this project. And I wanted her blessing because I understood it from the manufacturer's standpoint. And she's like, we need more people talking about this. So, oh my gosh, it's, my joke is this class I do is like therapy. It's like you get more relief because I would talk to people as the implant rep and they think you're this expert on it. And you realize that this topic might not have as much information about the topic as you want. And I remember like the way some people would ask questions, and I didn't understand why they were asking the question. They were asking the way they would ask it. So you take a topic like flossing, simply flossing an implant. Some people say no, never floss, and some people say yeah, okay to floss, and the answer is it depends.
And you bring up a really good topic because when you're talking about being an expert, okay, or at least having a high level of competence when it comes to implant dentistry on the manufacturing side and being a rep, right? Being a representative. And you sparked in me something that has happened to me because, when people want to know about the industry and, let's look around the corner and you see the consolidation that's happening with DSOs and GPOs and EIEIO. And there's a lot of private equity money that's coming in. And so people really want to know from the outside, from those on the inside that have knowledge, if you will. And when you look at implants and the intricacies and for the knowledge base, just to become, I've been in the implant industry for quite a while and, managed teams and on and on. To have a level of competency surgically, I think you can get there in about a year or two. Prosthetically, I think you hit the nail on the head. I used to say 10 years. You said 15. I think anywhere in that time frame is realistic, that you would have a level of competency to understand prosthetically driven implant dentistry from the manufacturing side. Now, I'm not saying from a clinical side necessarily, because I think others can get there faster because of the level of intimacy with procedures that they have. And when you think about that for a minute, the ability or inability for manufacturers and new implant companies to be able to penetrate into the market, it's kind of frightening. And then start to talk about how do you maintain in a responsible way these investments. And you see so many coming into the space, especially into the full arch space. And I was just speaking with somebody who their spouse is an oral surgeon at a major DSO in the full arch space, and was talking about the fact that they do a lot of zygomatic implant cases at their particular clinic. And it's about 40% of the work that they do. And more than half of those cases are fixing cases that have gone poorly. And I'm wondering, and I didn't get a chance to really drill down into it. I wonder how much of that is, it could be poor implant place, it could be a lot of things, but I'm wondering how much of it really has to do has to do with what you're talking about as well, that it's really longer term poor maintenance. And I have some concern that in the full arch space, that long term we may not be realizing some of the implications of lack of attention for what you're talking about and what you're doing, which is, and it's not even necessarily hygienists that work in implant practices, it's in general the field having comfortability and comprehension in being able to assess, diagnose, treat cases that come in, even if it's a practice that doesn't do implants, because those patients will show up. And so, what
And the
is your
long-term
take on
success of
how
these
do we,
cases,
yeah, and how do we establish a base level of competency for hygienists in implant dentistry to know I always use stoplights, right? The green, yellow, red, to be able to responsibly as an industry move forward. That we can still, because when profitability is king, and that's really, how much chair time are you spending as a hygienist, and how much is that chair worth, and in dollars and cents, to be able to be more responsible in that sense, to be responsible to the patient population. I'm curious about your thoughts on that.
the long-term success of this implant really has to do with how well the patient's maintained in that first year, because there can be bone loss in that first year. And if there is bone loss in that first year, that can really help predict the trajectory. So you really want to, that first year, bring that patient in on frequent interval. And if the patient is demonstrating poor home care, they're demonstrating copious amounts of biofilm and inflammation, they're not maintaining the implant well on a daily basis. And you can't just say, well, we'll bring you back in 3 months and see how you're doing. You need to, if there's inflammation, assess, give the patient a different home care routine, remove the biofilm, bring them back in 2 weeks to see if the inflammation's been resolved. And if the inflammation continues, this is my joke. This is why we call it practice. Okay, so that's not working for this patient. Let's try a different tool. And so, that first visit after the implants are placed and they're coming in and the sutures are removed and they're assessing, let's go over home care tools. Will a proxy brush be enough? Will an end tough brush be enough? Will a water pick be enough? And even with those 3 tools, can they use it effectively? Because you want the home care to be affordable. So you should include the water pick in as part of one of the tools for the patient to maintain. Is it practical? Will the patient actually use it? Will they not use the water pick because it makes their bathroom all wet and messy? Is it practical that they can actually implement it? Do they have enough dexterity and understand where the tools are to be used? Because there's patients who are going to think they just brush the plastic, the acrylic denture, and not understand they do need to get underneath to the intaglio surface and to the abutments underneath the denture. So it's getting the patient to understand at that level what they need to do. And if the patient doesn't understand, sometimes we as practitioners fail.
Yeah, and it's really what it sounds like is the core of what you do, which is that foundational education of hygienists and of clinicians and base foundation. So tell me a little bit about, with Practice at Your Best, the company that you've started, and in your experience, because you've been all over every aspect of the industry, right? From the sales side and the front end and the implant industry, and even before that in dental, but in the implant industry, working as a sales rep, working in implants, digital workflows, implementation, all of that. And then also as a hygienist, so you've seen those in clinically, and now you're bringing to the mass public, right? So now you're bringing to hygienists of here's a responsible way to be able to implement best practices for implant maintenance therapy. And so what are some of the tools, tips, and tricks? So let the cat out of the bag. What are some of the tips that you can share for hygienists or individuals? A lot of from the implant manufacturing side, clinicians that listen to the program. What are some of the tips, just high level tips that you can share, just off the top that they can take home, take away from listening to this, that are just some real basic high level points that are easy to understand?
Absolutely. The language that's important to the sales rep, the language that's important to the surgeon, the language that's important to the restorative doctor, and the language for the hygienist are all very different. So we just did this, it was a group effort where I spoke for an hour and a half, and then we had the attendees break and speak to different manufacturers' reps. And the implant rep talked about the threading and the cutting of the threading for the placement in the bone. So she missed that what was more important for the hygienist was the texture of the collar. And was the collar smooth or was the collar rough? And that affects plaque biofilm attachment. So what the surgeon looks at for the implant and what the restorative doctor looks at for the implant is very different than what the hygienist is looking for. So the restorative doctor is more interested in which torque wrench are they going to use and what amount of torque pressure are we going to use to place the final restoration. And the hygienist may not be removing the prosthetic unless they're in a practice that does see a lot of full arch. And then they may be removing the prosthetic and then they will need to know. But for the most part, that's a very high functioning office, the exception, not the rule. So a hygienist in a general practice needs to make the decision, do we leave the prosthetic on? Do we take the prosthetic off? Is the patient able to maintain plaque biofilm? Are the bone levels at the appropriate level? Are we taking x-rays once a year to confirm the bone levels are consistent? Is there presence or absence of biofilm? Is the patient able to maintain gingival health? And the answer is, if the bone looks good, the tissue's healthy, lack of biofilm, we're going to leave the prosthetic in place. The American College of Prosthodontics encourages not to remove the prosthetic if it doesn't need to. But you also need the right tools. So, and if the hygienist has a 4R, 4L and plastic, you can't effectively do anything with that type of tool underneath a full prosthetic. So where you look at, like, PDT has these Pinheiro scalers, and they're these little tiny half moon disc shaped cutting blades. They're very different than what a Gracie curette would look like. And they've got these contra-angled extended shanks to fit underneath the prosthetic. So with the right tool, with the right type of thin adaptive piezon with a peak tip, you can leave the prosthetic on and effectively treat the patient. But if the patient shows up and there's biofilm and there's inflammation and there's bone loss and patient's not doing a good job maintaining, this is the patient we do want to take the prosthetic off. And the office needs to determine, will the doctor take the prosthetic off? If I'm in Pennsylvania, we have expanded function dental hygienists or expanded function dental assistants. Are they going to be the person taking the prosthetic off? Is the hygienist comfortable doing this? Because it's not a hard task to learn, but you need a good mentor. You can't just throw it at somebody and just do it. You need a good mentor. And that's where the rep can come in and go over the technique. And, I was there holding hands with people as they were placing the prosthetic the first time. So for somebody who hasn't seen the surgery and hasn't seen the whole development of the prosthetic and be expected to remove the prosthetic and place it on is unrealistic. That's where you need that mentoring to make sure that if they do get themselves in that situation and something happens where they're not quite sure, there is that resource to help until they become more comfortable. So,
Yeah,
and then what do you do when you take the prosthetic off? There's the next level of the question. What do you do when it's taken off?
Yeah, right. What do you do when you now see these abutments and you're sitting here with a full prosthesis in your hand and you're looking at 4 multi-unit abutments, and how do they go together?
Leave the abutments on. Do not remove those multi-unit abutments off.
Yeah, exactly. Those knobs that you're seeing, those don't come off. You leave those. That's it. You leave that implant abutment connection. You and I both know that. Well, Lynn, this is the part of the program that all of my guests get to play. It's a little thing we call "What the Sleuth is Going On." It's 3 rapid fire questions. Everybody gets to play. It's the first thing that comes to mind. Are you ready to play?
I'm ready. Let's do this.
Okay. Question
Lightning
number
round.
1. What's the worst bad breath you've ever encountered?
Death breath. Oh my goodness. When practicing years ago, periodontal disease was so much more rampant. Just horrible. Oh man, yeah. We're smarter now. Patients take better care of themselves now. It was worse. It was worse when I was practicing in the 80s. Okay.
Yeah, you probably experienced quite a bit back then. Okay, good. Question number 2. If you could go back, if you could change one thing about your smile, what would it be?
Oh my goodness. Oh my goodness. I have such a steep overbite. Lingual verted lower anteriors. I just know what orthodontically is going on in maintaining them. Answered like a true dental nerd. Okay.
Like, okay, I'll be a little vulnerable. I got to tell on myself. I love it. Yeah, people do on this show. Absolutely. Okay, question number 3. If you could go back and be the inventor of any dental product, which one would you choose and why?
Ooh, wow. That could go in whole different directions, but I'm thinking the digital workflow. I would have loved to have been involved in that with the AI and just taking photographs and showing the difference year over year and explaining it and then showing it to the patient. I'd love to be involved at that level.
It is amazing, right? The AI work that's being done right now. And as we're speaking on this, I would love for you and I to do this show again 2 years from now, and for us to think back of oh, now they've got like the colored boxes and they're showing side by side. I mean, who knows what they're going to be doing 2 years from now? We could look back at this program and start laughing at about oh, we're just at the precipice of what we're doing. It'd be like, what are you talking about showing bone loss? Like now they're actually like putting bone back on or something crazy, right? That you're like, how did you even think of that?
I think the computers are going to take over. I think they're so smart, they're going to write their own programs. The computers are going to take over and we, the people, won't be needed.
When I use ChatGPT, I use please and thank you every time. Like, I want a good job when I'm the human underlord, not the overlord. Like, trust me, I know where my bread is buttered. I'm no dummy. All right. Well, Lynn, I want to respect your time. We're coming to the last few minutes of the program. Is there anything I haven't shared, I haven't asked you that you want to share with our listening audience today? Anything else? Any last words?
Oh, when I will return phone calls, emails, texts. So if somebody has a question and wants to reach me, you can find me on LinkedIn under Lynn Pencek. You can find me under Facebook under Lynn Pencek Minnie. I am Mrs. Minnie when I am not in the dental environment. That makes me Linny Minnie when I am married to my husband, Joe Minnie. And, I'm available. Facebook message, LinkedIn message with me. I am happy to return any questions. And I am available for your study groups or for consultation with your practice to help bring in a effective implant maintenance program so your hygienists can make confident decisions in implant maintenance care. Greg, thank you so much for this. I really appreciate it.
Absolutely. And we'll make sure that all of your contact gets into all of our show notes. And Lynn, thank you so much, my friend, to come on to the Two Sleuth podcast. It's been a true pleasure. Thank you so much.